Welcome to STEAM Pod, where I have conversations with women in STEAM to learn a bit about what they do and who they are. I'm your host, Michelle Ong. My guest today is Associate Professor Rhea Liang. Rhea is a general surgeon with a specialisation in breast surgery who also works in the area of surgical education. Join us as we talk about her journey as a surgeon, the Operating with Respect program, and her interest in manual crafts. Thank you for joining me today, Rhea. It's fantastic to have you on. And yeah, looking forward to learning a bit more about all that you do in medicine.
Mm-hmm.
Okay, so let's get going. How did you find yourself in medicine, or what drew you to med?
It is sort of like the default option in my family. So I am a fourth generation doctor. So I'd grown up in a household where my father I grew up in New Zealand, and so my father is a pediatrician of some renown. Um, he has in his professional life been awarded, Order of the New Zealand, what is it? The Officer of the New Zealand Order of Merit, which is the equivalent of an OBE. So those are pretty big footsteps to follow. But before him, even there was my grandfather, who was a physiologist, and not just the direct line, but you grew up in a family with lots of great aunts and uncles, and it's just peppered with medical people. So it's very natural because something I notice for the medical students, when they start medical school and start learning the language, it's like a completely different language. It's like learning, French or something, because there's so much terminology. But I didn't have that barrier because I'd grown up hearing about it and reading about it too. My father had bookshelves full of medical textbooks because in the pre-internet era, if you didn't actually have it on the bookshelf at home, you had to make a trip into the library. And if your local medical school library didn't have it, then you had to order it. So we had a very extensive medical library at home, and I think I remember as a 13 or 14-year-old already starting to pull them off the shelf and reading through them with quite some interest. And so you have a sort of baseline level of knowledge that makes it feel very comfortable as you go into medicine. And so I don't feel that I overcame any barriers. I just fell into what was done in our family in that regard. But we hadn't had a surgeon in the family for 2 generations. That was one thing that occasionally came up in family conversation.
Just the missing gap in the
Yeah,
family
lots and
tree.
lots of physicians of various specialties. I think we had a distant great aunt or uncle who was an obstetrician, but other than that, no surgical specialties for a couple of generations.
Wow. So was there any particular area that you wanted to get into when you decided you wanted to explore surgery?
No, not at all, because surgery was a late decision for me. So a lot of people make the decision to go into surgery at medical school. And I've watched them with some admiration, thinking, gosh, they're very ballsy and bold, but I couldn't do it. Training's too long. You have to stand for such long hours, and be hungry. And of course, that thing that's said very often to women, it's very hard to balance with your family. And so when I graduated, I actually wanted to be a GP. But as you started to get a little bit more proficient as a junior doctor, the surgical specialties, the wonderful surgeons in a little town called Rotorua in New Zealand, the bosses there started saying, you've got really good hands. You pick up these skills really quickly, and we think you'd make a good surgeon. And for a good year and a half, I think I kind of just dismissed that and thought, nah, I like the idea of the lifestyle of the GP. I love chatting to people. I have an innate curiosity in what they do. I'd love the variety. I'd love the flexible hours. And so it was an idea that grew on me quite slowly. And I felt I started on the back foot because a lot of my colleagues had put a lot of work into it. People were off doing PhDs, research projects, finding their networks. They had mentors. But once I kind of got my head around it in about PGY3, I went into it, and although my hands are tiny, so they're almost non-standard size, so I wear 5.5 size gloves, which in most hospitals I work at, you actually have to tell them to order those gloves, and they won't have them on the shelf. They're not standard
Wow.
supply. This was really challenging during my training because every 6 months you're at a different hospital,
Yeah.
so I'd ring ahead a month or two in advance. So please get these on the shelf because I'm going to need them when I arrive. Anyway, and so I loved little fiddly work. Ear, nose, and throat was gorgeous. Pediatric surgery, operating on tiny wee babies, was gorgeous. But in the end, it was the sheer variety in general surgery that drew me in. So from one operation to the next, you can go from sort of one end of the body to the other, really, in general surgery. And then as I got more into general surgery, the breast specialties appealed to me, because in the, I'm talking about the sort of early 2000s, breast specialty was a rapidly emerging field. The specialist aspects of oncoplastic surgery, and not just controlling the cancer, but also thinking about how we gave women back something that was beautiful and functional. So not just treating it as a purely physical thing to get the cancer out and get good margins on it, but also to think about how you planned that so that it looked, acceptable and functioned well as a breast afterwards. It was just personally appealing to me as a woman.
Yeah, and that's again like getting into your operating with respect thing. It's a big part, like when you're actually working in that area, because it's a part of who they are, and it's a part of their image, mental and physical, going forward after they have to have those kinds of surgeries.
Yeah, it is. And so the operate with respect thing, now that you've mentioned it, I mean, I don't know if viewers will be aware, but it's not just a tagline. Operate with respect is a multi-million-dollar well-resourced, well-supported initiative within the College of Surgeons that was born out of a very distressing event. So there was a Sentinel event in 2015 where there was a trainee was propositioned basically by her boss, and she declined. But the upshot of that was that there were negative repercussions on her future career because of the power differential. Now, the college, took the time to survey its fellows and its trainees and its IMGs to see how prevalent this behaviour was, and we were totally blown away by the results. So not only did we do quantitative work, but we did qualitative work as well, and the stories just poured in. And the amazing thing for me was it wasn't just the juniors, it wasn't just the trainees. We had quite senior surgeons writing in about how they'd always been damaged by the experiences they'd had. Humiliation, bullying, intimidation, and of course the sexualized aspect. So this caused, a great upswell on the support for addressing this type of behaviour. And operating with respect is one of 8 initiatives covered by a large plan called Building Respect. But the part that I chair, so I chair the Operating with Respect Education Committee, is to deliver training to the whole fellowship about how to change this culture. And we started off with an online module, which now more than 99.9% of the fellowship have completed. So the only ones that are still to complete it are those who are just newly becoming fellows. When you become a fellow of the college, you've got 6 months to complete that online module. So we're fairly well complete. And that was something that people said couldn't be done. They said you'll never deliver mandatory training, partly because you'll have a small nugget of people who don't believe it's important and can't be made to do the module because they're so senior that they're almost untouchable. And the prediction was that those would be the entrenched bullies or the entrenched harassers, who were often in very powerful positions. But the thing is, we've always portrayed it as an educative thing, not a punitive thing. It was like, surely this is something that we should all be aware of. Surely we all care for the safety of our patients and that our patients should feel safe. Surely we believe the educational literature that supports, teaching people in ways that don't involve intimidation and humiliation, because we abandoned all that in primary and secondary schools, a good 30 years ago. So it shouldn't be in surgery anymore. So that's the kind of approach we have. It's not been, if you don't do this, we shall. We do actually have some quite significant sanctions, tucked away for those who are persistently, behaving disrespectfully. But from the point of view of delivering the training, it's been as an educative thing. So getting to 99% took only kind of 2 or 3 years, and people said it could never be done. Anyway, so phase 2 is the face-to-face training. So we've developed now a face-to-face training workshop, which takes a day, simulation based, so they do role plays. And it's mandatory for the leadership groups. So the executive, the boards, the board, the committee chairs, the directors of all the courses that the college delivers for training. So that's about 600 or 700 surgeons are mandated to do that face-to-face workshop. It is a little bit on hold at the moment because of coronavirus. We can't expect people to actually travel to a workshop interstate because a lot of the interstate borders are closed, but we hope to have that reopened soon enough once COVID settles. And the idea of that is we've got about 7,000 surgeons all up active between Australia and New Zealand. So we think that if we train about 700 of them in how to manage and how to address it, then you'll have sort of sufficient critical mass in most places to really get all rolling into action. So the online module was about knowledge, and the shop is about action, getting people to actually speak up and do something about it when they see it.
Yeah. So internationally, how's this being received?
Really well, because everyone has the same issues, and so there are equivalent moves. So the College of Surgeons, the American College of Surgeons have got, now what's their one called? Time's Up Healthcare, as in time's up, time for us to sort this out.
Yeah.
And the British ones are all on the variations of something it out. So it started off with hammer it out, cut it out. I can't remember what the O&G people called it. Hope it's not push it out. Anyway. But each specialty had their own. So hammer it out is the orthopedic one, and cut it out is the general surgeon's one. And there's a bunch of hashtags you'll see around about these things. They've got a move from the physicians in the UK called civility saves lives, which is very similar. Yeah. So it's not just surgical colleges, but other colleges too. So we're all starting to talk to each other and look at each other's resources. But College of Surgeons, Australasian, has by far the largest volume of resources because we've just thrown so much money and so much sort of person power at it. And our resources are very well delivered because we've beaten all the bugs out of it through delivering the modules and courses repeatedly. It's quite mature material.
That's brilliant. Has there been a lot of difficulty in getting people to get on board with those kinds of ideas? Because it's not to say that media is accurate, but the stereotype of the jerk, top 1 percentile of your medical profession being bullies and, laying into trainees and patients and nurses and all that's a thing that you see all the time in the media.
Yeah.
So the fact that, it took this one event to trigger all of it off, like you'd expect a bit more resistance.
Yeah. We are to blame a little bit ourselves, but also media as well. Commonly as we're presented in TV and other things, the surgeon it's a lazy stereotype. It's very convenient to have the surgeon as the badly behaved, loud bully, who just rides roughshod over everything. But we're working on changing that. And so that's the external perception of us, but internally as well, we are guilty ourselves to a little degree. There have been conversations, where people have literally bragged about getting one over on the ED consultant, or no, I didn't accept that patient, not my problem sort of thing, and those are the sorts of conversations where we have to start calling it out and going, well, actually, let's refocus on the patient. What actually was the best outcome for the patient, and could we have helped facilitate that rather than seeing this as an us against them thing, getting it away from an adversarial approach to a team-based collaborative approach. So it's not, people think that this is an attempt to cut down the power of surgeons or to diminish their knowledge. And I'm saying, no, that's not at all it. We should still have the ability to decide when a patient needs to go to theatre and do the things we need to do. But I'm just saying, there is not the need to push other people down to achieve those things. And it works better if we're all facing the same direction, which should be towards the patient, to get the best outcome. So that's one aspect. And then the other thing we're very big on in Operate with Respect is this idea that you can't address disrespect with more disrespect. So we know from sociological research that those who are abused most often become abusers. We've seen it with domestic violence, we've seen it with sexual abuse, we've seen it with child abuse. And I get a little bit distressed when I see the commentary where people will say, hashtags like "don't be a dick," or people saying, "oh, they're a bastard," or whatever. You're like, well, to the degree that we are pushing back against behaviours that include name calling and stereotyping, then for us to try and address it by name calling and stereotyping isn't going to work.
Yes.
We have to be better than that. We have to take the higher road. And I understand it totally as a human reaction. It's totally human when you have been badly treated or disrespected yourself to feel like you want to push back. But we have to somehow find the grace and the maturity to not do that. And hopefully our juniors, as they come through, will see my generation. I think I'm sort of mid-career now. Hopefully the juniors coming through will see my generation start to model those behaviours and internalise it as the new normal.
Yeah, because all of it is learned behavior. That
Yeah.
It's not that they intend to go out that way. It's just that they see it, it's normalized, so they continue it.
Yeah, that's it. Getting back to your original question, yes, there has been a lot of pushback, and so everyone who works in this field, myself, my committee members, other people who are advocates, have sometimes found themselves silenced, or repercussions from vexatious complaints, or the quiet word from the head of the department saying, "Please don't make so much trouble," troublesome. But we should push on. I believe in the higher ideal. And I have noticed that although there were some very vocal objections to it, people used to literally stand up in conferences back in 2015 when we first launched it and say in front of a group of people all nodding in agreement, this threatens the foundations of surgery, and our patients are going to suffer if we can't get trainees who are robust enough to take the sorts of behaviours that we put up with, that they would literally say that in public. I find that although we still get that said in private now, people have, at least in social settings and public settings, realised that that is not an acceptable narrative anymore. That feeling that we did it and look how well we turned out is not a good justification. The same arguments had been made about things like corporal punishment in schools, or very punitive. The old jail system, was an idea to punish people until they somehow magically became good. We've moved away from that in so many systems in our society that there's not, it becomes increasingly untenable to hold on to it in surgery. Yeah, we can't punish people or put them under aversive conditions until they somehow magically become better. That's not how it works. We definitely need stamina. You do need stamina. You've got to be able to stand for long hours. You don't always get to sleep or eat when you feel like it. Those are things like sports people train for. But the bullying and intimidation, harassment, the negative comments, snide remarks, being dressed down in public, none of that helps anything. There's so much literature to show that decreases learning, decreases situational awareness, makes the whole situation unsafe. And it's not just for the recipient of that behaviour, but everyone else in the room. So lots of behavioural research showing that people who witness those events are also silenced. People come to understand that they should not speak up. And we've got very good evidence coming out in the literature now that increases patient error and decreases patient safety, so that complications, not just surgical complications in the operating room, but medical complications on the ward as well. The rates of pneumonia go up when there are incidents of unacceptable behaviour by surgeons.
Oh, that's interesting. Is that due to the psychological stress?
Yeah, you can only speculate as to the reasons why that might be. But, those of us, I think, rather sadly, I think all of us have experienced, even if not in surgery, we've all experienced a workplace that was like that. And you remember what it's like to just clock in, clock out, keep your head down, not speak up, and try and just do what you are asked to do. The minimum you could get away with.
Yeah.
And so innovation is stifled. People taking the initiative is stifled. People speaking up and thinking of better ways to do things is stifled. And all of that adds up to poorer outcomes for the patients.
And has that training reflected in those kinds of performance indicators in the clinics and hospitals?
Well, we're waiting for that. So one thing that we do know is that culture change takes a long time. And so there's something in behavioural change research known as the 2-generation rule. So if you think about things like, now that in Australia, it's, people don't smoke in public places. They just don't. People put on their seatbelts when they get into cars. They just do. But, it takes 2 generations. So there's a first generation who did it the other way, so who smoked in public or never wore seatbelts in cars, who with regular encouragement and reminding will learn to do it on a conscious level. All those ads about, make it click, or, there is no smoking in restaurants anymore, and all those ones about lung cancer, you can do it on a conscious level. That's the first generation. The second generation is the younger generation. They grow up in an environment where their parents or their seniors, the people who came before, are doing that consciously. And so for them, it just becomes an unconscious habit. So the same thing with surgery, my generation, the middle generation, will behave respectfully if we think about it consciously and keep reflecting about how we're coming across. We know from the original prevalence survey done in 2015 that half, so 49% of my generation experienced bullying, harassment, intimidation. So this is a very, very common experience, and it's been normalised. If we can all work together to behave consciously in these ways, then hopefully the younger generation will come through with the implicit assumption that people just behave respectfully in surgery. The stereotype of the surgeon in society, of course, will take even longer to change because there's so much media out there with, bold, brash, rude surgeons, that stereotype will take a long time to go. But so these things take time. So as to evidence about whether we're making an impact, the original Operate with Respect program had built-in evaluation time points, and the first evaluation happened last year, a very large piece of work involving both quantitative and qualitative surveys, as well as a textual analysis of all the policies and procedures and posters, adverts, communications, tweets, everything, all the text that's come out in relation to the building respect thing were analysed. Huge piece of research work. And it was very gratifying. So compared to the early days when we had a lot of pushback, we now have very strong support amongst the fellowship, amongst trainees, amongst international medical graduates, in excess of 90% for all of those groups. So we have the support of the fellowship. As to whether it's making a difference, we have got qualitative quotes from people saying, I put in a complaint in 2014, it didn't go anywhere. So that was pre-launch. I put in another complaint this year, which was 2019, and it was quite swiftly acted on. And so, I can see the change. And that's very gratifying to know that you're making a change on the front line, at the ground level. Yeah, because, all of us know from working in organisations that regardless of the policies that are in place, they'll often say zero tolerance for this, zero tolerance for that.
Yes.
But what actually happens on the ground may be a different matter. So to hear stories on the ground at the front line that things are changing is very gratifying. As to actual numbers, well, that will take time. Because it takes a long time for behaviour to change, and then it'll take even longer for the effects of that behaviour change to come through. But at the very start, with my diversity and inclusion hat on, I would like to see that the decrease in discrimination would, very shortly start to result in an increase in representation of, women, of LGBT, of people from metro and rural settings, of people from lower socioeconomic backgrounds, or those who are in the first in their families to go to university, a whole range of diversity that we don't currently have in the surgical fellowship.
Yeah, that's brilliant. Just being able to get more people into those areas where, we do actually need specialists and professionals in those fields anyway, because, we're always short on good medical staff.
Yes. You just need more diversity of viewpoints in the room. As I've gone round, I found, people seem to like to paint surgeons sometimes as, uncaring psychopaths, and I have actually met a few of them, but they are very much in the minority. People who know that they're wrong, but actually don't care. They literally turn up, in the morning wanting to inflict pain and suffering on people. But vast majority of people I have met are not like that. They do care. It's just that they have a particular upbringing and a background, and they don't understand how they're coming across. So things like, a complaint received from a young mother to a surgeon. The young mother the surgeon had made some throwaway comment about how well she was doing with how little she had. And she felt very offended because she is from low socioeconomic. She understood that she was coming to the consultation, looking a little bit disheveled, but she's doing the best that she can with what she's got. But she found it very upsetting. And then he wrote her a prescription for a drug that is arguably the best treatment for her condition, but for which she could not afford. And she didn't fill the script. And then she went back to the follow-up, and he I don't know quite what was said, but she felt that she was told off for not filling that script and that she wasn't given alternatives. And when you talk to the surgeon, they actually had very good intentions. They really honestly wanted the best for her, and they meant the original comment about how well she was doing in a very kindly way. But it was just that dynamic where they're older, they're male, they're clearly well off, and it just came across as patronising and a little bit patriarchal.
Yeah.
And then the second consultation where they said, why didn't you fill that script in? That surgeon actually thought that they'd said it kindly to say, why didn't you fill it in? But her reaction, which was just to clam up and be silent because she felt shamed, they found that quite perplexing. And so it was just that mismatch of communication. And I think if you had more surgeons who came from that sort of background, or who could talk about how hard it is to afford a prescription fee, even of $30, when you're on the pension, then those conversations, people who would just be more aware of different viewpoints and the diversity of Australians, and how those comments come across. And I'm learning in that space as well. Since doing diversity work, I've become so much more aware of things. I cringe when I think of some of the things I've said in the past, which might not have come across the right way because I simply wasn't aware. But we're not aware because we don't want to be aware. We're aware simply because those people aren't in the room.
Yes.
They're not in the room.
Because you only learn and experience what you've learned and experienced. So if you can't gain the broader experience of the people and the backgrounds that you're not familiar with, you don't realize what is or isn't appropriate or could be misconstrued in a negative way.
That's it. And so, as an example, I am, of course, an advocate for Indigenous representation. I grew up in New Zealand where Māori representation has been several steps ahead of Indigenous representation. So it was quite striking when I came to Australia. It was like taking a step back in time, thinking, gosh, they could do with some more Indigenous empowerment here. I mean, that's not to say that New Zealand has it all sorted, of course, but just to say, we can progress this a bit. But for years, I'd been abbreviating it to ATSI, ATSI, Aboriginal Torres Strait Islander. And it was only recently that someone pointed out to me that the actual Indigenous people here find that abbreviation quite offensive. And I'm just horrified. And the only reason I hadn't known was because we've not, in surgical circles, had enough Indigenous representation. And when we have, they've clearly not been empowered enough to speak up. When you think about, because we've only got 2 surgeons with Indigenous background, often the Indigenous representation is a community representative or someone from an Indigenous advocacy group. But can you imagine how intimidating it is to be sat in a room with a group of surgeons? They might not feel, clearly they haven't felt able to say to me, actually, don't use that abbreviation, until recently. Yeah, until recently. And so, this is the thing. It's not just having them in the room, but having them feel like they truly belong and empowering them to say something. I think those are actually separate steps. I actually think, we're doing quite well at getting them in the room now, or better at getting them in the room, but we're not necessarily empowering them to speak up. And that's not just for Indigenous, but a whole bunch of things. A whole bunch of dimensions of diversity. And I think that will greatly improve surgery as a culture, because in my experience, it's not for lack of goodwill. It's actually for just lack of, for just not knowing.
Yeah, that did make me wonder, like with the training, you've got this is how you should or shouldn't conduct yourself.
Mm-hmm.
But what about the communication aspect as well, on the other hand? So you might be having fewer complaints or they're resolved quicker, but are people feeling more, are they being trained or informed about how to be more communicative about the problems
Yes.
and about how to address them.
Yeah, we came to realize that the problem with the current system is that it's like a on-off switch. You either stay silent, um, and grumble to yourself about these things, or if you want to do something, it's like, here's the complaints line, or here's the HR number you have to call, or here's the formal portal that you put these things into, and then it all becomes bigger than Ben-Hur. There's an investigation, written statements have to be provided. It's often a very bruising experience on both sides, both for the recipient of the behaviour and the person who's accused of having dished it out, basically. So what we needed was something in between. And the in-betweeny bits is about speaking up and starting to have those narratives within your units. So rather than choosing off switch, which is stay silent, and on switch, which is go big and make it formal, you needed that in between. And so the Operate with Respect workshop, the one that's on hold for COVID, but the actual role playing is about practicing how to say, how to bring it up. And there is actually a structure of how to do it. It ranges from just tiny things to bigger things. So sometimes it's just a look or letting someone know that you heard. I've mastered the look that you give to toddlers. Someone says something that's a bit off color and you're just sort of like and they know that someone else has heard and thought, that's not quite on. Or just moving even your body language, it doesn't have to be verbal. So going and standing next to someone who's just been bullied, or coming between them and whoever's shouting at them, can be quite powerful. And then the speaking up, sometimes it can be humorous or just, or just kind of like, sorry, what did you say again? Or I didn't quite catch that. Can you say it again? Sometimes, quite often they won't say it again. Or going more than that, or just saying that's not cool, or right up to the point where you say, catch up with them shortly after the fact in a private setting and say, can I have a word with you about, what just happened there? Or, I heard about this that happened several days ago. Can we have a chat about it? So we teach the whole range of things from minimal right up to maximal before you get to the full-on formal report.
A full escalation, yeah.
Because the idea is that all the evidence shows that if you do more of that in-between work, there's less need for the formal complaint, because you address it in-house and there is that ongoing narrative about what's okay, because culture is what we do around here, how things are done around here. And people pick that up from what they see going on around them. So if they see rudeness or bullying happening unchallenged, then they come to understand that that is normal and accepted. Whereas if they see that someone kind of goes, yeah, that's not cool, or, let's refocus on the patient, we can talk about that later. Something like that makes it, starts to create that culture that the patient comes first, leave your bad behavior at the door, so that culture setting is really important. And hopefully if we do more of that, there'll be less need for the formal complaints, but also there'll be less need of the staying silent and keeping your head down maneuver as well.
Yeah, definitely. It's good, just encouraging the discourse and the engagement.
Yeah. Well, increasingly too, society is changing around us. So even outside of surgeons speaking up to each other, we find that year by year the proportion of complaints lodged with the college from the public is increasing, and it shows us that if we don't get our own house in order, someone is going to put it in order for us. I think the sorts of behaviours that were acceptable for surgeons 10 years ago are no longer going to be acceptable in 10 years' time. So we get reports that say, Dr. So-and-so was perfectly nice to me in the consulting room, but I saw the way he spoke to his secretary afterwards, not happy, and that's against, it used to be, the old narrative used to be, oh, yes, terrible bedside manner, but they're a good surgeon, meaning a good technical surgeon. But the public perception now, I think societal expectation is that the surgeon is all-rounded, that they are a respectful person, an honest, decent person, as well as a good technical operator.
Definitely. So what got you into the education side of things?
It actually started with the kids. So I had kids partway through my training, and when they started school, I thought, gosh, these classrooms are a bit different from the ones I remember. They just look like a riot. Kids running around everywhere, free choice of activities, teacher being very encouraging and praising them for efforts that I thought were quite mediocre. And I thought, but the kids were learning fabulously. They were just thriving in this. And I thought, gosh, this has changed. There must be something different about the underlying theory or beliefs about it that I need to bone up on. So I actually enrolled remotely in Bachelor of Arts, majoring in education, and started off reading about kids, kids primary schooling. But along the way, kind of thought, wait, why are we not applying this to surgery or any of the higher medical degrees? Why are the behaviours that we used to do, abusive questioning, put them on the spot and grill them until they cry, make them feel the shame of their lack of knowledge, so that they're more motivated to go away and read up about it. That as it turns out is a complete educational fallacy as well. If we've understood this for primary and secondary school students, why have we not understood it at a post-tertiary level, when it comes to higher medical training? So then as you start to have these slightly odd ideas, wandering around the halls of the College of Surgeons, I found a group of like-minded people, and so one of the first things I got drawn into was the revision of a course called Surgeons as Teachers, I think it was called. And it was a course that had been set up by two women, so Prof. Trish Davidson and Prof. Jennifer Martin, and they had set it up in 1999, and it was being revised in 2010, I think it was. And as I sat around the table revising this course, you just found yourself going, yes, and yes, imagine if we could teach all surgeons to teach like this. And it was just such a liberating, and, I had found my tribe, essentially. And I've been working, with that tribe ever since. And so since then, of course, we've revised that course. In fact, we're up to a second revision of it now, and it's been renamed. We've developed the Foundation Skills course, which is a one-day abbreviated version of that, which everyone who takes on a surgical trainee has to do. We've developed, leadership courses. We've developed communication courses. I mean, I'm not talking about me. I'm saying we as in the educational group. And then, of course, the operating with respect education has flowed on quite naturally from that. So it's just been such a privilege and really lovely, productive, if unpaid, work to be able to change, to contribute to the way that education is delivered from the College of Surgeons. So it's that old principle, you do the work that you're paid for, but you also do the work that engages you. And so, yeah, I mean, I'm very lucky myself. The surgery I do, if you get me started talking about general surgery or breast cancer, I have the same sort of look on my face. But education outside of that is kind of the portion of my time that I devote to pro bono work, because it is personally meaningful to me and productive.
Goodness. Yeah, definitely. Just being able to see the changes that you're able to affect in the greater community for your, for your own field.
Yeah, well, it's just a different thing. When I operate on a patient, of course, my focus is totally on that patient. And so for however many hours it takes, 2 hours, 4 hours, 6 hours, 8 hours, 10 hours, you are in the service of that one patient. When you do educational work on behalf of the college, though, you're actually doing it for the good of the whole profession. You know that the product you put out is going to eventually impact hundreds, if not thousands, of patients through the education of the surgeons treating them. So, in a way, surgical education is sort of like the public health effort of surgery. It is something that has an effect on a much wider scale than what you actually do day to day with your scalpel.
Yeah, definitely brilliant. Just being able to focus on both, your patient and also everything else around it that's part of your circles.
Yeah.
So, what do you love about surgery?
It's the crafting of it, but combined with the people-facing nature of it. So you'll remember I said I'd started off wanting to be a GP, and that's partly because I just love finding out about people. I find people, the whole diversity of humankind, really diverse. And so my notes are peppered with comments about things like, belongs to the African Violet Society, or, or is due to take the trip of a lifetime around the Mediterranean, or things like that, which aren't strictly speaking to do with their medical issues, but speaks to them as a person, and to some degree probably does impact on their health, because we are doctors. We graduate from med school before we become surgeons, so we're all doctors. And we look after patients in a holistic way before we learn to pick up the scalpel. And so, those are just little comments that I love to put in the notes, because they bring colour to the patients. They make them alive for me. And so, so there's that people-facing aspect of surgery, but also the crafting of it. So anyone who's ever done a handicraft, fishing fly tying, or wood whittling, or needlework, or anything, the hours just pass by. You're just doing the activity, you're totally engrossed in the activity, and when it turns out well, when you get a good product, you have that sense of satisfaction. I mean, by the same token, if it doesn't come out well, you're like, and you take it all, do it again until it's to your satisfaction. Yep. There's that feeling, but it's that combination. And so when I first started operating, it was the same thing. You're just so engrossed in that moment. You're thinking, how shall I bring this together so it looks good, works well for the patient, fixes the original problem they turned up with. When you step back from the table, it's almost like time didn't pass. You step back from the table and suddenly you're aware of how hungry you are, and the fact that your back's bursting and that you really ache across your shoulders, but you were almost unaware of it till that moment because you were so engrossed in it. Yeah, it's almost a form of meditation. It's a strange thing to try and describe. People say it's like being in flow. Flow is actually an educational concept. If you can, when you're teaching kids or whatever, if you can find something that gets them into the flow of things, that aha moment when they really get into something, it's a wonderful thing to behold when you're a teacher. And so I think I had that moment, as a surgical trainee. Yeah. So it's just nice to be able to do something to people and to fix whatever it was they came in with. And of course, I did choose a hard specialty. I do breast cancer, and so we can't always fix things for people. So you have to get good at the other side too. Sometimes no matter how many hours you slave away, you will come to recognize that the tumor cannot be fixed. So sometimes you have to, so you have to develop those skills where you've got to sometimes go out and tell people bad news.
Because it's such a big thing to have to share, how do you develop the skills to manage the emotions that come along with that?
And as a trainee, I felt like I was an odd bod, because the traditional way of approaching it was to be very professional. There are lots of acronyms for how to deliver bad news. How to deliver bad news is a common topic or lecture subject during medical school, and it's all very, make sure you have a private space, follow these steps, follow the steps, but
it's all very clinical.
It's very clinical, yeah. And I, as you can gather, wear my heart on my sleeve. I cannot help conveying the emotion in myself. And so I was actually criticised during my training for being too emotive. And of course, that feedback was often given with a fair dose of gender microaggression thrown into it. Don't be such a woman. Grow some balls, Rhea. But as I've become a more mature clinician, I've found that actually is the right way for me, and that patients do appreciate it when you show them how upset you are that you've tried your darndest and you can't help them the way that you would like to. Patients do appreciate that. They appreciate that I'm distressed. I will accept, I will admit to having had a quiet cry. I don't lose control in front of them, but the occasional tear does sneak out and I have to reach for the tissue box, but, often they have too. And that's a very human moment. I don't think that we should hide that as a profession. I don't think it takes away from our professional knowledge or our compassion or anything to show some emotion. And I'm super glad to find that times have changed to match. It's the conversations I'm seeing in social media and also anecdotally from friends and family who have been on the patient side is that society in general would like doctors who are not professional, or rather that we've reconceptualized professionalism to not be that cold clinical, sits behind the oak desk and conveys your information to you.
Yeah, because you're humans too.
Yeah,
You're people with
yeah,
feelings. Yeah.
yeah. So yeah, so I don't seem to be the odd bod anymore in that regard.
Yeah,
Thankfully.
it's good. It's good to see that gradual change.
Yeah, yeah.
Okay, so we might start to move on to those extra questions now.
Oh yes.
And I guess we sort of know where this is headed. What hobby or interest do you have that's most unrelated to your work?
I pondered this question and I just cannot think of a decent answer because there's a lot of hobbies that I thought were unrelated.
But they sort of are.
But they sort of are. Like I'm famously a crocheter and a needleworker. Um, and, you know, back when I'd only just started on Twitter, I had a tweet unexpectedly go viral when I only had a few hundred followers, I think, because basically someone had called me out for taking my knitting to a surgical conference. Um, and so they called me out for knitting in a surgical conference. And of course, there was this huge outpouring of response from people who are knitters and crocheters, not all of them women either, saying, but I actually can't concentrate if I'm not doing something with my hands. And then we had wonderful comments from neurobiologists saying, that's exactly it. This is the whole thing about tapping pens or jiggling your leg or those fidget spinner things. People need some sort of repetitive motor thing to manage the motor overflow. If you don't manage the motor overflow when you're having to sit still, you're using up too much cognitive load thinking, oh gosh, I have to sit still to concentrate on what's going on. So it actually improves your concentration to do some repetitive motor movement, but arguably pen tapping and leg jiggling is much less productive in terms of making baby blankets
Yep.
and scarves than picking up
Yes.
a crochet project. Anyway, so once upon a time I would have said that's totally unrelated to surgery, that's my hobby. But then the more I think about it, I'm like, no, it's manual skills and, the ability
It's
to
manual
be
skills, it's the
precise.
craft. Yeah.
Yeah. And to stick at one thing for hours and hours. And, fine
Getting into
motor
the flow of it.
movements. There are parallels to it. Yeah.
Definitely. Like it's rewarding work being able to work with your hands and being able to do that in your profession as well as in your, out of hours time. It gives you a lot of stimulation mentally and
Yeah.
physically to be able to
Yeah.
see something come
Yeah.
together. So I can understand and appreciate
Yeah.
the love of surgery.
Yeah.
And I've spoken to another person in medical STEM who has said the same thing. She said that she loved microsurgeries because it's just being able to work with that level of detail and intricacy.
Yes. Yeah. And to the degree that we spend a long time teaching trainees how to stitch, teaching them the mechanics of stitching, it's like, well, why don't we recognize prior learning? People who have been doing needlework for years, I do find that they pick up the principles of stitching human bodies together much more quickly because they understand, how things distort or pucker, what we mean when there's length discrepancy between one side and the other and how to adjust it, the principles of tension. Everyone knows that if you're knitting something or crocheting something, if there's too much tension, it's not going to work. These are things that we don't have to explain to people who have these skills already when they come into surgical training. And I often think, it's a slightly cheeky thought, but wouldn't it be a wonderful thing if we recognize things by learning, to understand that people with those skills are already, well on the way to becoming a good trainee. Mm.
Yeah. Is that something that anyone else has kind of slipped in? It's like, oh, if you're learning to become a surgeon, you should take up some needlework.
I have rather cheekily a suggestion for people of all genders, approaching me to say, if I'm interested in surgery, what can I do to prepare myself now? And I was like, well, take up some manual craft. I don't really care what it is. I've had a trainee recently who was a keen fisherman and ties his own fishing flies, and he had the same dexterity and understanding of things like tension, neatness, precision, how to tie knots. It was the same sort of thing. we got through that phase of training really quickly because of his prior knowledge.
Yeah, well, it's all that small manual
Yeah,
detail work. Like
yeah.
it's something that requires the practice and the dedication to be able to get
Yeah,
right.
so I'm like, I mean, there have been cheeky papers, actual research papers published about, whether people who play video games would be innately better at laparoscopic surgery. Because it's that same thing with, your eyes are at the screen here, but your hands are working down here. It's the same thing
No,
when you do
that's
laparoscopic or
fair.
telescopic surgery. You have to train yourself not to look at the work
Yeah, you're not looking at what
your
you're
hands
doing.
move
Yeah.
separately from where your eyes are. So there have been research studies showing that people who play video games might be better suited for laparoscopic surgery, and they're yeah,
Well, they're related.
yeah.
And which childhood book holds the strongest memories for you?
Well, there was a childhood book that I absolutely loved called The Phantom Tollbooth. Um, and it's an imaginary journey of a boy who travels through a whole bunch of different lands, the land of words and the lands of numbers. And it's just clever. And even as an adult rereading it now, I find a lot of enjoyment in it. But it made a lot of impact on me because it's just so imaginative and beautiful when I was a kid. But also, what makes it particularly special now is that it's also a favorite of my kids. And so there's that feeling that
Oh,
you're
brilliant.
passing on that joy in that story onto the next generations.
Yeah, it's great. Yeah, being able to share what you grew up with and what you loved growing up with your kids is definitely, it's a good
Yeah.
feeling. And lastly, what advice would you give someone who wants to do what you do, and what advice should they ignore?
Well, they should ignore anything that says, you're not suited for it, or, so I have variously been told I was too small, because I am a 5 foot tall, 40 kilogram Asian woman, too small, too weak, um, too feminine, and not feminine enough. You're like, oh, can't win. Um, Too outspoken and not speaking up enough, overconfident and underconfident. So all of that sort of thing, it's like, well, that has no bearing on how you're going to perform as a surgeon. So all of that sort of advice, just ignore. But if you do want to be a good surgeon, funnily enough, my advice is, you will spend hours and hours and hours of time just as part of your normal job working on the business of surgery. You know, our famously long hours, long operations, you're going to spend plenty enough time on that. But what I find about consultant surgeons, the ones who are the best, are those who have had a really broad life experience. They've traveled, they've read, they've got lots of interests, they have other hobbies, they have a wide circle of friends, not just surgeons. They are honest, decent people who understand the perspectives of lots of different people. And they make really good team leaders and they make really good surgeons. They appreciate the different priorities that their patients might have. So I actually just tell them to go and live a little, really, have a broad experience. And so they often say, oh, but I can't do that within the surgical training scheme because it feels, it's so famously competitive that you've got to put your head down, get your higher research degree, butter up some mentors to write you nice references and work your way up the promotion ladder so that you get more and more senior towards registrarship. That's how it feels. So they often say there's no space for me to take time off or go traveling or whatever. And I'm like, look, I took the whole of my PGY3 year off to go backpacking around the world. And everyone said it shouldn't be done. No one would give me a job when I got back. I was taking myself out of surgical selection. It would be looked, the gap in my CV would be looked on poorly. None of that came out to be true. And the same when the first pregnancy was accidental. So all of a sudden I'd fallen pregnant, and there was some pushback from people saying, oh, this is very inconvenient for us as a training program, very hard to work around this, you sure surgery is the right thing for you, blah, blah, blah. But that worked out as well, and of course I was never going to give up on my beautiful kids. So, I would have much rather given up the surgery than given up on the kids. So, but just to say, I had to fight. We literally did not have a maternity leave policy. We borrowed one rather hurriedly to make it work. Same when I got to the breastfeeding bit. I was still breastfeeding a child when I came back to work, and there was no provision for rooms to pump in or anywhere to prepare the bottles. So we had to kind of get a little bit heavy-handed with the work workplace legislation and say you are actually legally obliged to provide this. So yeah, but it all worked out. It's like, here I am, a consultant surgeon, you know, part of, I appreciate that it's hard enough simply becoming a surgeon. It's a long, hard path, but along the way, if you can show that other things are possible and maybe change a few policies to make it easier for people behind you to come through, then that's also very worthy work.
Yeah.
Yeah.
Definitely. Just have to persevere for what you want.
Yeah. Yeah. I have not yet met anyone who I think is unsuited to be a surgeon, because when people say a person is unsuited for surgery, what they're saying is there is a very narrow stereotype of a surgeon. And I'm like, so rather than saying to people, this person is unsuited to surgery, how about we just say, well, how about we broaden out the stereotype then? Because we don't all have to be like each other. Mm.
It's interesting. Like when you said unsuited to surgery before, I was thinking unsuited because they've got hand tremors, because of things that would actually interfere with the physical work. And it hadn't occurred to me that it was about personality traits and physical traits. Yeah.
Yeah. No, being told that you're the wrong race or the wrong gender or the wrong size, wrong personality, there's this perception that you've got to be bold and brash and confident and outspoken. There are surgeons now who are very quietly spoken, excellent surgeons, and actually the patients really appreciate their style, if it matches their style. It's about, on a market level, providing a wide diversity of surgeons so that patients can have choice. If they want someone who is of LGBTQI orientation to understand their particular issues, they should be able to find someone like that. That's not possible at the moment. Or if they specifically want a female surgeon, well, at the moment you've got your choice of the 13% of the fellowship that's female. It's not much choice. In a lot of centres, there are none. That sort of thing. If you want someone who speaks your language, because you're an immigrant and you're a bit worried that people won't understand your cultural requirements, those choices should be available to the public, and we can't at the moment offer that in surgery, and we should. Yeah, I mean, the thing about hand tremors, we do have surgeons who have hand tremors, and also when they get older, almost every surgeon has hand tremors. Surgery is not just about operating, so surgeons can contribute a lot to surgery without actually operating. If they choose to become an academic or research surgeon or a teaching surgeon, or to get into the administrative aspects. Those people with a wealth of lived experience as a surgeon, as they get older and the hand tremors get in the way, they still have so much to give to the profession of surgery. We don't capture that very well at the moment. They just sort of stop operating, and that's that. We don't capture.
And that's a shame. Yeah.
But also the incoming technology is going to improve things. So already in things like neurosurgery, there are technologies where if the robot is doing the surgery, the robot will self-correct for your tremors. It's the same technology as in motion picture, movies.
Yes.
You don't get the camera, the technology adjusts for the cameraman's tremor. Sort of like, well, that technology promises to extend the working lifespan of surgeons, for example. You wouldn't have to quit at 60 or 65 just because of the tremors. And for a specialty where famously we become consultants later than any other specialty because of the length of the training program. So it's unusual to become a consultant surgeon, anywhere until your sort of early to mid 30s is fairly typical. So if you're going to have to quit operating by the time you're 60, you're really, the productive lifespan is very, very short compared to other specialties. And it's sort of like, well, if the technology is coming that will allow you to extend your ability to operate on people and accommodate for the changes of aging, why should we put any limitations on people on the basis of those sorts of physical limitations? Yeah, and so not in Australia, but we do. There are surgeons around the world that have, dwarfism, for example, and need to stand on a tall stool to operate. That sort of thing. There's been a lot of discussion about surgeons who, for various reasons, lose the sight in one eye and lose stereoscopic vision, through bicycle accidents or whatever. They find ways to adjust as well. And so you're thinking, right, if we would accept consultant surgeons who lose their sight of one eye after they achieve consultancy, then what is actually stopping us from accepting trainees? Because I'm like, look, are they driving a car? Almost always they are. If they can drive a car, surely they can drive a laparoscope. because people say they've got no depth perception because of the stereoscopic vision. And you're like, but if they're driving a car, they figured it out somehow. It's just starting those conversations around, informal conversations to make people reflect and think, when we think of a surgical trainee, what do we actually think of? What are we looking for? Is it purely the technical aspects, or do we want other aspects as well? And I know that I'm quite, on one end of the spectrum to say we want diversity, right? Maximum diversity, the better. But, like I would be so delighted if we could get a hearing impaired surgeon, someone who's fluent in sign language, because I think there would be a population that would dearly love to have a surgeon they could
benefit
sign with.
Of course.
Yeah.
And when you're having to face something so invasive, you want to be comfortable with the people you're working with to provide the care.
Yeah. From the point of the view of the patient, as you're lying flat on your back with your arms strapped down on the boards and you're hearing impaired and all you can see is lights and sounds and people's mouths moving, it's like, wouldn't it be so amazing to have a surgeon who could sign to you as you went to sleep? I just think that would be such a powerful patient experience. We as far as I know, we don't have anyone in the profession who can do that. And anyone who is hearing impaired who applied, I imagine they would get, at the moment, still a fair bit of, microaggression or discrimination, saying, but why? Why would you want to do surgery? Are you suited? Unsuited for surgery.
Yeah. Definitely. Lots of obstacles still to overcome.
Yeah. And of course, it's not just surgery. Those barriers exist in a lot of medical specialties, but, it's up to odd bods like me to kind of just gently question people and make them think a little harder about how we define these things.
Yeah. And it's, medicine is, you're providing care for people, and there's more to it than just the actual physiological aspect.
Yeah. And people come in all shapes and sizes, and the doctors should too.
Yes. Definitely. It's a good way of looking at it.
Mm-hmm.
Okay. Well, thank you, Rhea, for this conversation. It has been absolutely amazing to learn about surgery, what you do, and also about, operating with respect and the way that the Australian medical field is moving towards, taking those things into consideration going forward.
Yeah.
So if people would like to reach out to you, what would be the best way to reach out to you?
Yeah, so I am a very simple surgeon. Social media was a complete unknown land to me until 18 months ago, and I can only manage one platform, so you won't find me on Facebook or Instagram. I just cannot figure out how anyone finds the time to manage more than one platform. So I can only manage one platform, that is Twitter. So I am there at Liang Rhea, very, imaginative handle, sorry, but you will find me there, and just, hit me up with a tweet or a direct message if you want to find me. It's the easiest and quickest way.
That's brilliant. Thank you so much, Rhea. Yeah. And I hope I hope people get something out of this amazing conversation.
Oh, it's been my pleasure.
And
the more I bleat on about these things and the more people hear about these ideas, the more we can spread them around a bit.
Oh, most definitely.
Yeah.
All right then. Okay. And thank you so much.
Thank you.
Have a great day. I've loved speaking to Rhea about her experiences in medicine and surgery, as well as the Royal Australasian College of Surgeons Operating with Respect program. Programs like this in Australasia and around the world will require a lot of time and effort to effect a cultural shift, but by challenging the stereotypes that are also perpetuated in the media, it can only lead to better outcomes for patients, as well as a more healthy environment for those working in the area. To learn more about Rhea and what we discuss on this show, or to connect with us, please visit the STEAM Powered website at steampoweredshow.com. You can also reach out to Rhea on Twitter at Liang Rhea, Liangrhea. If you enjoyed this conversation, please let me know. Subscribe to this channel, leave a comment below, and share this with your geeky or geek-curious friends. You can also support Steam Powered on Patreon and Ko-fi under Steam Powered Show, the links for which will also be in the show notes. Thanks for watching!